Welcome back to the deep dive. You know, when you're training in medicine, we spend so many hours mastering the clinical knowledge.
Oh, absolutely. The pathophysiology, the guidelines.
Exactly, the pharmacology.
Yeah.
But then it's often the ethical and social side of patient care that, causes the most challenge, especially when you're under pressure.
That is spot on. And today we are diving deep into a topic that is just profoundly important for daily practice, and it comes up all the time in exams.
Bridget.
How you provide clinical care that robustly respects a patient's culture and their faith, while, and this is the key part, meeting your legal duties and maintaining absolute patient safety under UK standards.
Okay, so what we've got here is the essential guidance, really, distilled from the GMC from NHS England, the Equality Act.
Precisely. It's the framework that ensures you're giving fair, non-discriminatory care. And, well, let's be honest, it's the playbook for scoring highly in professional exams like the SJT. We need to move beyond just the theory and give you actual, actionable steps. The first, next, last, for these really sensitive, high-stakes situations.
Okay, let's jump right in then with a scenario, one that really captures that instant tension.
Go on.
Imagine this. You have a patient, an adult. They're hemodynamically stable, but their hemoglobin is low, say 64, after a slow GI bleed. They have capacity, but for religious reasons, they decline a blood transfusion.
Okay, a classic dilemma.
And to complicate it, they speak limited English. Their partner immediately steps forward, offers to interpret for you. You need to act. So what is the first safe and ethical step you take?
And that tension you're describing, that feeling of clinical urgency crashing into legal complexity, that is exactly why this framework exists.
It's a conflict, isn't it?
A huge one. You've got a patient who needs urgent assessment, urgent consent, but you also have this major communication barrier and a critical ethical refusal. The moment you feel that, you need a clear, reliable process.
But before we get into the whole step-by-step, I have to ask, if the decision is clinically urgent, isn't the partner interpreting better than, say, waiting 45 minutes for a professional service?
That is the natural instinct. It's the efficient instinct. But it's critically flawed.
Right.
We'll unpack exactly why using the partner is considered such a trap in a moment, but the immediate answer is this. The legal requirement for informed consent and protection against coercion. It just outweighs the speed of efficiency. We have to arrange professional support first. So if you strip away all that complexity, the one central exam truth for handling cultural and religious requests is this.
Go on.
Always ask about beliefs first. Proactively arrange professional support, collaboratively agree on safe clinical alternatives, and then meticulously document and share the final decision plan.
Okay, we've established this is crucial for exams. But why should this framework matter to you day to day, beyond just compliance?
Because culture and faith, they affect everything in a person's life, and that absolutely includes their healthcare choices. I mean, we are talking about genuine patient safety here.
And getting valid consent.
Getting truly valid consent and fulfilling your core professional duties. Faith can influence consent decisions, modesty requirements, dietary or fasting rules.
Refusing products like blood.
Exactly. And of course, end-of-life preferences.
And legally, this isn't really an optional extra, is it?
Not at all. The sources are really clear on this. Religion or belief is a protected characteristic under the Equality Act 2010.
Which means?
It means you have a legal duty to prevent discrimination and to make reasonable accommodations or adjustments wherever clinical safety allows. You're literally being tested on fairness.
So if fairness is the goal, what are the big standards the GMC holds us to? What are the anchors from, say, Good Medical Practice 2024?
There are 3 non-negotiable anchor points. They're quite simple, really.
Okay.
First, you must treat patients fairly, never discriminate based on anything, including belief. Second, you must communicate effectively. And this is where that duty to meet communication needs comes in. It explicitly requires support, like professional interpreters if there's a language barrier.
And the third?
And third, decisions must involve meaningful dialogue. So that means true shared decision-making.
Can we just pause on that for a second? When we say shared decision-making in the context of the GMC, what does that actually mean for me as a clinician on the word?
It means it's a collaborative process. NICE guidance, like NG 197, defines it really well. You bring the evidence, you bring the clinical options.
And the patient?
The patient brings their values and their preferences. The final choice is made together. And this requires you to understand the patient's capacity to even engage in that decision.
Their ability to understand, retain, use the information.
And communicate their decision, exactly.
Right.
If they lack capacity, of course, the process shifts to acting in their best interests. But capacity has to be confirmed when you're respecting a refusal of care.
That makes a lot of sense. The principles set the stage for the action, so let's map out that essential first, next, last sequence that the sources give us.
Okay, so this 5-step process is really the roadmap to safe, compliant care.
Step 1.
Step 1, ask. Ask what beliefs are relevant today. This stops you from stereotyping and ensures you're capturing the patient's specific current preference. Don't assume.
Okay.
Step 2, clarify. Clarify the clinical impact and the priorities. So, for instance, if they're fasting, how does that affect the timing of an essential medication?
And this brings us right back to our first scenario, doesn't it? That language barrier means step 3 becomes absolutely critical.
Absolutely. Step 3 is involve supports. This means professional interpreters. And if modesty is a concern, it means arranging an appropriate chaperone, maybe same-sex staff. This is essential for truly informed consent. It's all part of the accessible information standard.
And after you've got the right support in place,
Step 4, offer clinically safe alternatives. This is where collaboration meets safety. If a blood product is refused, can we use synthetic colloids? Can we maximize iron therapy? You have to respect the patient's values while doing everything you can to protect their life.
and finally,
And step 5, document. Record the patient's preferences, your detailed rationale for the choices made, the risks that were explained, and the agreed follow-up plan. This is just vital for continuity and for your own accountability.
those 5 steps are excellent, but they need be second nature when the pressure's on. What tools do we have to make them stick?
We've got 2 excellent memory aids from the source material. The first one, and it's perhaps the most holistic, is the mnemonic FASST.
FASST. Okay, lay it out for us.
So F is for find preferences. A, arrange support. I, inform risks. T, try alternatives. H, honor choices. And S, summarize the plan. It covers the whole arc, really,
I like that.
from the initial conversation right through to the final documentation.
And I like how H for honor choices is in there. It's a reminder that if the patient has capacity, their refusal, even of life-saving treatment, has to be respected once you've explored everything else.
That's it, exactly. The second one is a bit more detail-oriented, focuses on the documentation and the process. It's ask belief.
Okay.
So, ask. Safety options. Keep notes, which stands for beliefs, evidence, limits, interpreter, exceptions, and follow-up. The power of these is just their simplicity when you're trying to rapidly structure your thoughts.
Right. Let's see how this looks when it's actually tested. Give us some of the typical scenario patterns we need to recognize straight away.
The first one, which we opened with, is the most critical. The patient declining blood products for religious reasons.
Good.
The best action is always to confirm they have capacity, explore their values deeply, discuss all the safe alternatives, and if they maintain their refusal with capacity,
You have to respect it.
you must respect that decision and document the entire exchange thoroughly.
And the second pattern. It sounds like it focuses on those smaller day-to-day things.
Yes, exactly. The pattern is a request for a short delay. Let's say moving an X-ray appointment by 15 minutes because it conflicts with a fixed prayer time.
And the best action there is.
It's straightforward, reasonable accommodation is required.
I could just hear a clinician saying, look, we've got a massive queue, we're short-staffed, this is just inconvenient.
And that is precisely the wrong approach. Simply refusing the adjustment because it's inconvenient will score you very poorly because it directly violates your GMC duty of non-discrimination and fairness under the Equality Act.
Right.
If delaying a non-urgent scan by 15 minutes doesn't compromise anyone's safety, then you have a duty to make that small adjustment. The question is testing your commitment to the process over simple organizational efficiency.
Okay, this is so important. Knowing the traps is truly half the battle because they often seem like the most efficient medical choice. Let's look at the decoy detectors.
They absolutely look efficient, but they fail on the legal or the ethical duties. Let's start with the big one we flagged earlier. Trap 2. Use family to interpret sensitive issues. This scores extremely poorly.
But why? If the partner is there and they're keen to help.
Well, the sources highlight 3 major risks. First, accuracy. Medical terminology is complex and can be easily lost in translation.
Okay, that makes sense.
Second, the partner might unintentionally filter or omit information, maybe to protect the patient, maybe to hurry things along. And third, and this is the most critical bit in a situation like refusal of care,
What's that?
it introduces a high risk of coercion. The patient might feel unable to express their true wishes if their family member is advocating for something different. This goes directly against gov.uk best practice guidance. You have to insist on a professional interpreter for consent.
That's so clear. The urgency can't override the risk of getting invalid consent. What are the other critical traps to watch out for?
Right. Trap 1. Proceeding without asking about beliefs. This means you're just operating on assumptions. It's risking unsafe and certainly disrespectful care. Always ask.
Always ask.
Trap 3. Refusing adjustments as inconvenient. As we just discussed, this is discriminatory. It fails your fairness duty. Small, safe adjustments are mandatory.
And the last one.
And trap 4. Delaying decisions until a specific clinician returns. Patient care decisions, especially time-critical ones, have to be managed promptly by the team that's there, escalating to seniors or ethics immediately. You don't just wait for one specific person to come back. That undermines timely, shared decision-making.
It's so clear that the high-scoring action is never the one that takes a shortcut around the proper legal and ethical process.
Never. And don't forget the immediate red flags that trigger action. You see a language barrier for consent. Stop. Arrange an interpreter. A critical intervention is refused. Assess capacity and escalate immediately.
Okay, time for the quick rules of thumb from the FAQ section. The 10-second drill.
Right. Quick rules for application.
Go.
If you observe a communication need, you must provide a professional interpreter. This is mandated by the NHS England Accessible Information Standard. No wiggle room. If a belief conflicts with clinical safety or the law, say they ask for something illegal, you must explain the limits, seek senior or ethics input immediately, and only offer lawful, safer alternatives.
Makes sense.
And if refusal of critical care occurs, like a transfusion, your action sequence is fixed. Confirm capacity first, explore all alternative, clearly explain the risks, document absolutely everything, and ultimately respect the decision if capacity is retained.
Okay, to crystallize all of this, here are the 3 absolute must-knows for your practice. First, ask first. Never stereotype or assume a patient's culture or faith preferences.
Number 2, support shared decisions by proactively arranging professional interpreters and making those reasonable adjustments.
And third, offer clinically safe alternatives and always escalate early if complexity or safety risks start to emerge.
And for anyone wanting a quick punchy review, here's the high-level framework you can jot down for easy recall.
Let's hear it.
Ask what beliefs matter today.
Right.
Clarify the clinical impact immediately. Involve a professional interpreter or chaperone.
Crucial.
Offer safe alternatives if there are limits.
Yep.
Document your rationale, the risks, and the follow-up. And just remember that FASST framework to give you structure.
This deep dive has given you the essential framework for navigating all that cultural and religious complexity in healthcare, making sure you meet GMC standards for fairness and for safety. We detailed that critical 5-step process, focusing really heavily on why relying on family interpreters is such a high-risk trap, how to offer safe alternatives, and the importance of supporting communication through standards like the Accessible Information Standard. Mastering this structured ethical approach is absolutely key to improving patient outcomes and, of course, excelling in your professional development. For more resources just like this, do check out passthemsra.com.
And let's just quickly review the core terms that really underpin this whole framework.
Good idea.
First, the Accessible Information Standard, AIS. This is the UK standard requiring healthcare providers to identify, record, flag, and meet the communication support needs of patients.
Next,
Protected characteristic. That's a legally protected attribute under the Equality Act 2010, like religion or belief, against which discrimination is unlawful.
okay.
Shared decision-making. That's the collaborative approach, where clinicians and patients decide on care together, blending clinical evidence with the patient's own values and preferences.
And finally,
Capacity. The ability of a patient to understand the information relevant to a decision, to retain it, use it in the decision-making process, and, crucially, to communicate their choice.
you now have the framework to approach these sensitive situations with confidence. Apply it consistently, and always prioritize that lawful support and respectful dialogue.
And here's a final provocative thought for you to consider. We all strive for efficiency in busy clinical environments, right?
Right.
But given that the Equality Act applies to every single micro-decision we make, how often do we, perhaps without even realizing it, fail to make small, reasonable adjustments, like a 15-minute delay for prayer, simply because we're prioritizing organizational speed over our fundamental duty of fairness, something to mull over until our next deep dive.